Good afternoon.
So good afternoon, ladies and gentlemen, and dear colleagues. It's my privilege to invite you once again to this sixth meeting of Medanta Echo and Cardiology today and tomorrow. This meeting in which you all have graced us for the last so many years, almost a decade. But because of the pandemic, we had to now change it to a virtual meeting, which we do every almost last Saturday of every month. This is the sixth such meeting, and truly it's my privilege to invite you once again to join in. You have all supported us in the past, and surely you will be with us in our scientific endeavors in the future too. I hope so. The chairman of this symposium today is Dr. Krishnam Raju. Dr. Raju and I go back to a long time when we were together at the All India Institute of Medical Sciences as DM students, and Dr. Raju was my immediate senior and helped me navigate through the exigencies of cardiology training at AIMS, and I'm deeply thankful to him. And I will hand over the mic to Dr. Raju now to start the proceedings. And I would like to wish Dr. Manjuran and Dr. Satish Govind good afternoon to both of you, and good afternoon, Dr.
Good afternoon.
Raju.
Good afternoon.
And it's all yours, Dr. Raju. And of course, Dr. Manish Bansal is with us. So both of us will be there at the end of the session for Q&A and whatever. So Dr. Raju, over to you.
Okay. Thank you very much, Ravi. And welcome to our faculty of today, Professor Manjuran, Dr. Satish Govind. Now it is a very, very interesting session in the sense, a lot of new things have happened in the last decade or so. This session is being called Shooting from a Distance. It sounds a little obscure from the sentence of that, but I must tell you that this is a very, very interesting part of clinical cardiology as well as echocardiography from multiple angles. So the first speaker will be Professor Rajan Manjuran from Kerala. He is going to speak to us on suspected cardioembolic stroke, how to evaluate. And the second speaker is Dr. Satish Govind from Bangalore. He would speak to us on patent foramen ovale and various issues regarding that. And the patient with cryptogenic stroke and PFO, whether to close or not to close, when to close, what are the ifs, buts, nuts, screws, etc. What is the latest evidence? What is the current status? What we need to know, what we need to do. That is what Satish is going to speak to us. First speaker will be Professor Rajan Manjuran. The topic of his presentation will be suspected cardioembolic stroke. Those of you who may or may not be familiar with the numbers, I must tell you, roughly 1/3 of all cerebrovascular accidents are cardio-aortic systemic embolic strokes. This, we became aware of it some 20-25 years back, and this science has evolved so much. Now we are very eager to listen to Professor Manjuran. Professor Manjuran, now you are on.
Thank you, Krishnam Raju, for the introduction of the topic, and I will share my is my screen visible?
Yeah, yes. To me, yes.
Slides are also visible?
Yes, to me.
Yeah, okay. I hope it is visible to other participants also. Good afternoon, everybody. As Krishnam Raju has said, the suspected cardioembolic stroke was recognized almost 10-15 years ago. People started recognizing that a good number of ischemic stroke are due to an embolism, either from the heart or from the aorta, and this is being recognized more and more frequently. So how to evaluate? Embolism of cardiac origin accounts for about 15 to 30% of ischemic strokes. So almost up to 1/3 of ischemic strokes can be due to a embolic episode. Echocardiography is the best and most reliable and easy to perform investigation to detect cardioembolic source. When to suspect cardioembolic stroke? Of course, this is a neurologist field, but the kind of situations when a cardioembolic stroke is suspected are abrupt onset of stroke symptoms without preceding TIA, more extensive and severe neurological involvement, multiple cerebral infarcts, underlying heart disease like presence of atrial fibrillation, mitral stenosis, mitral regurgitation, or previous myocardial infarction. Embolism to other arterial territories also indicate that it could be embolic in origin. The diagnosis of cardioembolic source or stroke can be confirmed by detecting the potential source. Let's look at what are the cardiac causes of embolism. Major risk sources include patients who are in atrial fibrillation, patients who had a recent myocardial infarction, previous myocardial infarction with LV aneurysm, cardiomyopathies, cardiac masses like intracardiac thrombus, intracardiac tumors, fibroelastomas, especially menantic vegetations, or even other vegetations, rheumatic valve heart disease like mitral stenosis, aortic arch atheromatous plaques, endocarditis of various types, mechanical valve processes. All these are major sources for cardioembolic stroke. In addition, there are few minor or unclear risk sources which include mitral valve prolapse, mitral annulus calcification, calcified aortic stenosis, atrial septal aneurysm. These patients with atrial septal aneurysm do have higher incidence of patent foramen ovale and paradoxical embolism, giant Lambel's excrescence. All these are minor sources of embolic episode. Atrial fibrillation probably is the most important reason for embolic stroke. In atrial fibrillation, normal contraction and emptying of left atrial appendage does not occur. And most of the times, the embolus, the thrombus occurs in the vicinity or in the left atrial appendage. This leads to stasis of blood in left atrial appendage and to thrombus formation. Transthoracic echo will not be able to visualize the left atrial appendage well. However, tiltal parasternal short axis view, aortic valve level, and apical four-chamber view may image left atrial appendage in some patients, especially when the left atrium is large, as in a patient with mitral stenosis. Transesophageal echo is the gold standard to evaluate left atrial appendage and to detect thrombus. Here is an example of a patient where we could see the left atrial appendage, from transthoracic view. This is very clearly seen. The patient has a large left atrium. This is not very common, where you can easily see the left atrial appendage from the transthoracic echo. The left atrial appendage and the clot detection is really easy when you are doing a proper transesophageal echo. Here is an example of a left atrial appendage clot in a patient with where a transesophageal echo easily detected the left atrial appendage clot. Patient had mitral regurgitation and had paroxysmal atrial fibrillation. Here is an example of a patient with a very huge clot in the left atrium. And these patients are at high risk of embolic episodes. Actually, this patient we operated as within 2 days, and a huge mass of clot was removed from the left atrium. The left atrial appendage dysfunction can be detected by transesophageal echo. Low emptying velocity and spontaneous echo contrast in left atrial appendage indicate dysfunction. In left atrial appendage dysfunction, the peak emptying velocity will be less than 30 centimeters per second. Some people consider even less than 20 centimeters per second as the evidence for left atrial appendage dysfunction. But in general, consensus is 30, less than 30 centimeters per second velocity at the mouth of the left atrial appendage, which can be evaluated in a transesophageal echo, will tell us about the left atrial appendage function. How can we predict there is a risk of embolic risk in a patient with atrial fibrillation? Patients with LV systolic dysfunction, when ejection fraction is less than 35%, left atrial appendage thrombus or spontaneous echo contrast, reduced left atrial appendage emptying velocity of less than 20 centimeters per second, enlarged left atrium with increased left atrial volume, especially if the volume is significantly increased. That is a pointer in favor of increased risk for thrombus formation. Atrial fibrillation and atrial stunning. Atrial stunning can occur following electrical cardioversion. Atrial stunning is detected by a low emptying velocity of less than 20 centimeters per second in the left atrial appendage. Most often, atrial stunning disappears in 48 to 72 hours after the patient has regained normal sinus rhythm. Some of the patients, it may take up to 2 to 3 weeks. A normal left atrial appendage function by transesophageal echo within 7 days of cardioversion indicate low embolic risk. Mitral stenosis with atrial fibrillation is a very high risk category because mitral stenosis patients have stasis of blood in the left atrium, they have a large left atrium, and there is a very high risk of thrombus formation, especially when the patients are in atrial fibrillation. The high risk of thrombus formation because of stasis of blood in left atrial appendage as well as in left atrial cavity. Clots can be found in left atrial cavity. Spontaneous echo contrast is very often detected in left atrium. Here is an example of a patient with mitral stenosis. He has not yet formed a clot, but you can see the echo contrast, spontaneous echo contrast. Here is an example of a patient with ball valve thrombus. Sometimes patients, nowadays it is very, very rarely seen because most of the patients with mitral stenosis are either where they undergo a balloon mitral valvuloplasty or get operated, and hence it has become very, very few. But occasionally we get patients with ball valve thrombus. All patients with atrial fibrillation need both transesophageal echo and, if possible, transthoracic as well as transesophageal echo for evaluation. Esophageal echo evaluation prior to electrical cardioversion can reduce the need for prior 3 weeks of anticoagulation. Patients in whom no clot is demonstrated in left atrium by transesophageal echo can confidently undergo electrical cardioversion. Otherwise, they require 3 weeks of anticoagulation. In patients with atrial fibrillation, after cardioversion to sinus rhythm, left atrial appendage function can predict risk of embolism and recurrence of atrial fibrillation. Ideally, the velocity at the left atrial appendage should be more than 30 centimeters per second. LV thrombus is another situation. In acute MI patients, the LV thrombus can be detected in 7 to 20% of anterior myocardial infarction. Nowadays, it is becoming very less because most of the patients undergo aggressive treatment with primary angioplasty, and most of them regain almost near normal LV function. So the risk of embolic thrombus in the left ventricle in a patient with myocardial infarction has significantly come down. In a recent study of more than 8,000 patients, the incidence of the prevalence of left ventricular thrombus in a patient with myocardial infarction was less than 5%. But the clot is most often seen in the LV apex. If the patient is having LV aneurysm, then the risk of thrombus is almost 50%. The LV thrombus is best detected in apical views. The LV thrombus is usually attached to an akinetic or a dyskinetic segment. In doubtful situations where it is not clear whether there is a LV thrombus or not, contrast ultrasound agent injected intravenously can detect the LV thrombus. Here is an example of a thrombus. Here is an apical thrombus. This thrombus is attached to the inferior wall. It is projecting into the LV cavity. It is mobile. these are higher risk candidates for embolic episodes, and these are actually flat and attached to the endocardium, so hence a lower risk of embolic episode. When the patient is having suspected, you are suspecting that patient may be having the thrombus in LV, contrast echocardiogram can always bring out the thrombus. Actually, you can see the filling defect both at the apex as well as on the medial aspect, and this patient is having an thrombus in the LV cavity at the, near the apical region and requires oral anticoagulation. The LV thrombus prediction of embolism: large thrombus, protruding thrombus, thrombus which are protruding into LV cavity, mobile thrombus, and in old people, there is a higher risk of embolic episodes. In the evaluation of LV thrombus, transthoracic echo is superior to transesophageal echo. That is because the transesophageal echo do not pick up the LV effects very well. So transthoracic echo is found to be superior to transesophageal echo in the detection of LV thrombus. The sensitivity and specificity of echocardiography to detect LV thrombus is on 95% and 86% respectively. What is the recommendation? Transthoracic echo is the best investigation to detect LV thrombus following myocardial infarction. Large, protruding, and mobile thrombus has the highest risk of embolization. Cardiomyopathies and thrombus formation. Dilated cardiomyopathy patients with poor LV function are at high risk of LV thrombus formation. This is because of the stagnation of blood in the left ventricle. Patients of endomyocardial fibrosis are prone to thrombus formation. This is because their endocardium is replaced by fibrous tissue and it becomes a nidus for thrombus formation. Idiopathic LV non-compaction can predispose for thromboembolism. The risk of thromboembolism in dilated cardiomyopathy in various reports varies from 1.7 to 3.5 per 100 patient years. So it is not very high. So unless the patient is having an associated another risk factor like atrial fibrillation, just because the patient is having dilated cardiomyopathy, LV dysfunction, and is a high risk candidate to have embolic episodes, or rather there is a risk of thromboembolism, that is not an indication for oral anticoagulation. Here is an example of a patient who is practically severe LV dysfunction, and you can see the patient is having spontaneous contrast also, echo contrast also. Here is a patient with non-compaction. You can see he has got a severe LV dysfunction also, and the non-compaction patients, there can be the blood can get into the crypts of the non-compacted segment, and the stagnation of blood can occur, and the thrombus can be formed. These patients are also at the risk of developing thromboembolic complications. Patent foramen ovale and systemic embolism. I think this will be dealt with by the Satish, but just to mention a few points, PF exists in 1/4 to 1/3 of all adults. PFO can have a right to left shunt flow, right to left flow during Valsalva maneuver or coughing. Presence of atrial septal aneurysm in a patient of PFO increases the risk of paradoxical embolism. It is thought that the atrial septal aneurysm can act as a net, capturing the thrombi and bringing to patent foramen ovale so that it can cross to the left side and result in paradoxical embolism. In the setting of pulmonary embolism from multiple venous thrombi, paradoxical embolism through PFO is possible. So if there is a shower of emboli coming from the deep veins into the right atrium, and if the patient is having a patent foramen ovale, that patient has a risk of paradoxical embolism. Even though the PFO is a source for paradoxical systemic embolism, this is an area of clinical uncertainty. I'm quite sure that Satish will make this clinical uncertainty more clear to us. Here is an example where the patient with multiple thrombi into the right atrium from a deep vein thrombosis. And of course, this patient did not have any paradoxical embolism. But if the patient is having a patent foramen ovale, then there is a risk that there can be paradoxical embolism. So what is the recommendation? Transesophageal echo is the gold standard for detection of PFO, even though transthoracic echo can also pick up PFO. Presence of atrial septal aneurysm increases the risk of paradoxical embolism through patent foramen ovale. And we will be listening to Satish more about patent foramen ovale. Cardiac tumors and embolic risk. Echocardiography is the best investigation to detect intracardiac tumors. Cardiac myxoma is the commonest benign primary tumor of the heart. Embolic phenomena can occur in 30 to 40% of patients with myxoma. Myxoma which are friable and familial are at risk of embolization. This is the group of myxoma which have got high risk of embolic episodes. Papillary fibroelastoma is a tumor attached to valves and at a high risk of embolic episodes. There is an example of a left atrial myxoma in a transthoracic echo. Very seen with great difficulty, but it's very clearly seen when the patient underwent a esophageal echo. You can see the large left atrial myxoma in that patient, where it is picked up very easily in a esophageal echo. Anything related to left atrium, I think always you must look through the esophageal echo. The vegetations, the myxomas are very often friable and at a high risk of embolic episodes. Sometimes vegetations can be attached to other locations. This one is attached to the mitral valve. So friable vegetations are the myxomas. Commonest primary cardiac tumor. Commonest site is left atrium. Most often single. 5% can be multiple. Irregular shape, non-homogeneous, areas of calcification, petangulated, and freely mobile, and many of them may be non-homogeneous and fragmented. And these are the ones which have high risk of embolic episodes. Cardiac tumor can be detected by echocardiography, particularly by transesophageal echocardiography in left atrial location. Friable and familial myxomas are at risk of embolic episodes. Papillary fibroelastoma. These are usually small tumors. Actually, it may mimic infective endocarditis vegetations. They are seen in relation to the mitral valve. Here you can see the papillary fibroelastoma. You can see the same one here. It looks like a infective endocarditis vegetation. And you can see another example of a papillary fibroelastoma attached to the aortic valve. It's attached to the aortic valve. You can see there's a stalk which is attached to the aortic valve. This is seen in relation to valves, most often seen in relation to mitral valve. They simulate vegetations, but unlike infective endocarditis vegetations, papillary fibroelastoma is seen on the downstream side of the valve, while vegetations are seen on the upstream side of the valve. That is a very important differentiation. The papillary fibroelastomas are seen on the downstream side of the valve, and infective endocarditis vegetations are seen on the upstream side of the valve. Mostly no symptoms and they're harmless. Rarely superimposed thrombus formation on the papillary fibroelastoma can result in embolic episodes. Infective endocarditis vegetations. The infective endocarditis predisposes for systemic embolism from vegetations varies from 10 to 50%. Risk of embolism is highest during the initial phase of antibiotic therapy. Studies have shown that if the antibiotic therapy has been there for 2 weeks, then effective antibiotic therapy, then there is no risk of embolic episodes. So here is an example of vegetations in the mitral valve and in aortic valve. One important aspect of prosthetic valve infective endocarditis, very often it may be missed in the transthoracic echo. You must always do a transesophageal echo. Here you can see the vegetations from the left atrial side of a patient with a prosthetic valve. So these are the situations where the echocardiography can predict the higher risk of embolic episodes like vegetation size, the fungal vegetation, Staphylococcus aureus infective endocarditis, and if the mitral valve endocarditis, especially anteriorly fled endocarditis, have a higher risk of thromboembolic complications. So all cases of suspected infective endocarditis must have transthoracic echo or transesophageal echo examination to detect vegetation. Large mobile mitral vegetations are at increased risk of embolization. Prosthetic valve has got a risk of thrombus formation, and they can have even other intracardiac devices and they can have embolic episodes. Patients with prosthetic valves are to be evaluated with transesophageal echo if embolism is suspected. Large prosthetic valve thrombi are more prone for embolism. Miscellaneous conditions like mitral valve prolapse, mitral annulus calcification, calcific aortic stenosis, aortic atherosclerosis are also sources for embolism, but much lower risk. What is the role of CT and MRI? Essential to differentiate ischemic from hemorrhagic stroke. Embolism to other organs like spleen can be detected by CT and MRI. So what is take-home message? Embolism of cardiac origin contributes to 15 to 30% of ischemic strokes. Atrial fibrillation is the most important cardiac condition leading to embolic episodes. Assessment of left atrial appendage for clot and dysfunction by echocardiography, preferably transesophageal echo, is the most important evaluation of atrial fibrillation patients at risk of embolism. Detection of mobile large apical clot in patients of myocardial infarction indicates risk of systemic embolism. Various forms of cardiomyopathies are at risk of thrombus formation. The risk of paradoxical embolism in PFO is higher in presence of atrial septal aneurysm. Friable and familial myxomas are prone for systemic embolism. Up to 50% of patients with infective endocarditis, especially with large mobile vegetations, are at risk of embolism. In all cases of suspected embolic stroke, a cardiac source of embolism must be looked for by echocardiography. Thank you so much for your kind attention.
Thank you, Professor Manjuran. I think we'll take the questions after the second session, second lecture. I invite now Dr. Satish Govind from Bangalore to move on to the next lecture. It will be patent foramen ovale in a patient with cryptogenic stroke. This is a major issue between cardiologists, neurologists, cryptogenic stroke. It's a very exciting, very interesting, very stimulating topic. And whether to close or not to close, what is the evidence as of now, what is the current status? A lot of things have happened, and a lot of controversies are there. It has been going on for the last 15 years. Dr. Satish, over to you.
Thank you, sir. Good afternoon to all of you. With an excellent presentation from Dr. Manjuran, he has set the tone, and my focus will be on PFO in cryptogenic stroke. Let's just look at the very term cryptogenic stroke itself in the beginning. In terms of stroke, when we look at the causes, there are quite a few. So you can have atherosclerosis, there can be hypocoagulable states, the valves can be causative anatomy, the left ventricle can be one, AF is another cause, and then there is atrial cardiomyopathy. But what we are going to focus upon today is the patent foramen ovale. Now, the types of ischemic stroke are atherosclerotic, there is cardioembolic, lacunar, and this very important entity called as cryptogenic stroke, which is about 25 to 39%, where there's no identifiable cause. It's also called a stroke of unknown origin. So the very word cryptogenic means it is obscure, it is unknown, or of uncertain origin. Now, the definitions of cryptogenic stroke, there are quite a few. The one which is very sort of accepted and which is used quite a lot is the one from what is called as the toast, where it came from the studies which looked at in the beginning of when they were looking at cryptogenic strokes. So here, this is called as a brain infarction that is not due to cardioembolism, not due to large artery atherosclerosis, and not due to small artery occlusion. And here the cause is not known despite extensive vascular, cardiac, and serologic evaluation. The other definition, which is a little more complex and complicated, not so widely used, is what is called as the Causative Classification of Stroke System, the CCS, where they look at multiple parameters, the ECG, the echo, imaging parameters, and then there are these 5 categories. So it's basically an algorithm which is not sort of really helpful in a clinical practical scenario. And then there is less use, the ASCOT, where the atherosclerosis, small vessel, everything is sort of taken. Again, it's the same thing, but put it in a different way. And here the scoring is based on numbers, based on absence, causal, and where it's uncertain, potential, unlikely. So you have these various sort of numbers depending on how lethal it is going to be. Now, the workup for cryptogenic stroke itself starts in a sort of broadly in a three-pronged way. One is the immediate assessment, where the clinical evaluation is done, and then an immediate CT of the head, and then the 12-lead ECG is taken. After that starts the preliminary assessment. So it is again divided into cardiac and neurological. So there is the Holter over there, and then the echo, both transthoracic and transesophageal. And then from the neurological side, the MRI brain, the carotid ultrasound, and then the angiographic assessment, the vascular imaging in terms of CT and MRA. And then not for every patient, but in select patients, one can go deeper into looking at causes, looking at hypocoagulable states, and then cancer screening, vasculitis, arteriopathy. So the diagnosis is more of a ruling out of multiple causes. The next way of sort of looking at cryptogenic stroke is in terms of what exactly it's in terms of numbers. So where does it really give a problem? There's not much of gender difference, but what is of importance is the recurrence which happens. So at 1 month, it's about 4%, and then it sort of starts going up. At around 2 years, it's about 20%. And at 5 years, it has been documented as 33%. And when it is associated with the septal aneurysms, and there is a significant shunt, and when there is atrial septal hypermobility, there is a strong association of PFO with cryptogenic stroke. Now, when it is associated with PFO per se, the recurrence is low, but when it is with the ASA or the septal hypermobility, it goes up. And even with medical therapy, it is about 4.6%. So it is very important that we sort of look at this condition in view of its very significant recurrence which happens. Now, the other important point is to look at a patent foramen ovale. So this is just a very simple way of looking at it. So there is a fossa ovalis here, and the foramen ovale happens when there is no opposition of the flap here, and you have a passage, and one can see that the flow actually happens from this direction, where especially when there is a eustachian valve or the IVC flow, which sort of directs it. So this is where the problem is going to be. So the patent foramen ovale, and then you have this variation, atrial septal aneurysm. The septum can go in different directions. This is the other extreme of the pathology of the interatrial septum. The imaging, so this is how it looks like. So you can have a very sort of floppy, thin atrial septal aneurysm, and it can go in both directions. In this particular patient, you can see that it is more towards the left right atrium, and this is the one which can be dangerous in terms of thrombus, which can be hidden inside, or when there is shunt, which as you can see here from right to left. So this is the one which is important, and that is the focus. Now, the PFO per se, it is commonly sort of quoted as 1 in 4 in people in the population. So the detection rate with transthoracic is about, just a minute, please. The detection rate is about 10 to 24 with transthoracic, and 39% with TE. It goes up with TE, and then 36% at autopsy. So to help the clinician to find out which PFO is the one which is likely to cause, score has been developed. So this has been based on about 12 cohorts which were looking at cryptogenic stroke, and this is called as the ROPE score, or the risk of paradoxical embolism score. And the idea is to predict how likely a PFO is going to be a causative factor in cryptogenic stroke. And this is just to guide management. So it is not going to be a primary parameter. It's not going to be one of the main ones, but it is a very helpful score which has been widely discussed and quoted and which is used, but it should be used in conjunction with other parameters and not to solely depend on it. The risk of the ROPE score itself, it has got 10 points. So higher the score, that means more likely the PFO is the causative factor. And it also gives a risk of recurrence in terms of percentage at the end of 2 years. So for example, if there is a young person with no risk factors, the score is going to be quite high. The topic of debate based on this over the last 2 decades has been that is PFO an incidental finding in cryptogenic stroke, or whether the prevalence of PFO itself is a cause-effect relation. So this is something which is very contentious and which has had a lot of sort of studies which have looked into it. So the question is to close or not to close. The story of the closure itself starts somewhere actually from 1992, when the first the look at data and to look at whether it should be closed started in 1992. And during the 90s, on and off, there was some little data, and there were people in the US looking at it whether to close. But the momentum really sort of gained from 2000 onwards, and this is where some of the studies, the prominent studies, started to focus upon, and where the numbers started to come, and then the publication started to happen. So one of the earlier studies, this is the closure study, then there was the PC study, and this is the HD approval, which is primarily a pre-market FDA approval, but the data was not very conclusive. And at this particular point, you can see that there was a withdrawal of the device. But then again, the studies started in terms of the reduce, and then there was the respect, which started to gain momentum. And as the years went by, the data started to accumulate, and then somewhere at 2016, it started to gain a lot of traction. At this point, it started to come into clinical scenario. So there is a long sort of a timeline here, and presently it is in the clinical scenario. Now, the PFO occluders used in the RCTs are the Starflex. These are the bigger ones, the prominent ones. So this was used in the closure study. And then there is the Amplatzer, which was in the respect and other studies also. And then the reduce study looked at the Gore cardioform, while the closed study looked at multiple devices, so almost up to around 11 devices. So these are the various devices which have been used. Now, let us look at how the studies look at in terms of performance. So this is the closure one, and then there is the PC study, and then the respect study. So this was in 2012 publication, 2013, and it didn't show any change. And at this point, there was a lot of skepticism. The data was not forthcoming, and it did not show anything sort of positive. And from 2017 onwards, there were these 3 big studies. So the respect study, the reduce, and the close. So these got published in NEJM, and that's when the data showed that it really brought down the recurrent stroke and almost up to 100% in terms of a few years, so 2 to 3 years at that point. And that is when the FDA got it approved, and then it came into clinical practice. Now, in terms of why these earlier studies did not do well, so the closure and the PC study, their patient cohorts were mixed. They included TIAs, even lacunar strokes, and the cutoff, the criteria were not really great. And then the PC and the closure study, especially the device itself, was not very successful in terms of the quality of the device and the successful outcome of the device implementation. But the respect and the close and the reduce studies showed that the recurrent stroke events improved, and we showed remarkable improvement in terms of the reduction. And that is because they had a better cohort in terms of the way they screened their patients. They made sure that these other patients were taken out, and then they focused on patients who really were sort of going to benefit. So the atrial septal aneurysms, patients with large shunts, and then the deep strokes were taken out, the lacunar infarct. So that is why the data started to come out in a positive way. Then in terms of how it was going to be helpful, one can see from here the freedom from the events in terms of stroke, TIA, death. So this orange one is the device, and then again, in both the recurrent stroke as well as the primary composite outcome, you can see that the freedom was really high. So this is where it was really sort of very significant. But there was a little bit of focus as to how they sort of really benefited. So they started to look a little more deeply, and they started to look at the anatomy, and then they started to look at the actual PFO itself. And they found that the PC trial the number of the type of septum that was used, where the PFOs, where they were not really large or there was not much of hypomobile septum, while the RESPECT studies had a higher number. And this is where the focus started to sort of really be looked at in terms of they would be a better cohort, and they are the ones who are going to benefit, the ones with the atrial septal aneurysm and the large shunts. And the DEFENSE PFO trial, which came out in 2018, this was a Korean study. And this again, they focused primarily on large shunts. And this again showed a very significant change in terms of the stroke outcome remarkably coming down. And this further reinforced and added to the data which was already there. So these trials, the DEFENSE, the RESPECT, the REDUCE, the CLOSE are the ones which are the mainstay right now, which is quoted whenever the PFO closure is looked at in cryptogenic stroke. In terms of safety, in terms of serious adverse events, there was not much of difference. In terms of procedural complications, anywhere from 2.4 to 5.9. But what really sort of stood out was the atrial fibrillation. So this is where this is the only talking point in terms of safety. This was a pre-procedural and post-procedural, where there was slightly higher atrial fibrillation seen in these patients. This was one, apart from the fact that the procedural risks were also taken into consideration. There's been a lot of meta-analysis, a lot of reviews, so many of them looked at bias. So the performance bias has been generally good. The CLOSE and the REDUCE showed some sort of performance bias. And this is from the European Heart Journal. This is in 2018. And again, generally a good sort of overall quality, got a good approval in terms of how it was. So the quality was high for the RESPECT and also for PC, so intermediate for the others. So overall, by and large, the quality of the data from these studies have been good. Then as far as the societies were concerned at that particular point, so we can see from 2010, starting from European Society of Cardiology, the chest physicians, the NICE, the AHA, and then the American Academy of Neurology. So it's always been, should be considered, can be considered, looking at special relationships. So nothing was really sort of really forthcoming, but it was only in 2017 when the FDA gave its approval, suddenly it became a class 2B. So this again sort of brought into consideration. Many people were not very sort of accepting to it because they looked at the data in a different way. But with 2B again, not really sort of great, but it got its acceptance from the FDA. So this was the turning point where these studies, the REDUCE, the CLOSE, and the RESPECT, when it got published in NEJM, that's when the turning point happened. Now, as far as follow-up is concerned, again, the follow-ups have been around 5-7 years. So especially for young cohorts, this is still really not that much, but they are increasing. So this is a publication in 2019. So they have looked at more than 10 years. And here again, very low rate of ischemic events. So it looks sort of good in terms of the device. So what is it presently? So the question now is not about whether it is to close or not to close. It's a question of which patient to close. So this is the article title from the European Heart Journal, and this was in 2020. So it is just about which patient should get the device. So there are many sort of algorithms. I'll just run through a few of them. So this is from the BNJ Rapid Committee, so which sort of simplified it. PFO, cryptogenic stroke, no AF, no aortic disease, no left side heart disease, no cerebral vascular disease, and the treatment options are fairly simple in terms of PFO, anticoagulants, antiplatelets. And then depending on the options, so if anticoagulants were not there, and if both were there, so and then if the PFO is not accepted, so these were the options that were available in terms of 3 comparisons. So the expert panel at that time in 2018 made a strong recommendation in favor of PFO closure plus antiplatelets, and this was compared with antiplatelet therapy, but a weak recommendation when it was compared with anticoagulants. And then there have been other sort of algorithms, the flows which have been given. So this was published in 2018. Again, the same thing. One has to rule out all these conditions. And if it is not there, And it depends on the patient's quality of life in terms of outcome, in terms of sickness. So if it is quite okay, then the PFO closure is advocated. But then again, these are the caveats. So there should be prior venous thromboembolism, and then there should be an MRI or stroke, which says that there are multiple cerebral defects, large PFOs, septal aneurysm, and eustachian valve or Chiari network. So these are favorable conditions for PFO closure. So in terms of the PFO itself, it has to have a long tunnel, and then the septal aneurysm has to be more than 10 millimeters, multiple orifices. These are the ones at risk, and a thick septum, and also the presence of eustachian valve or Chiari network. As far as the societies are concerned, I'll just run through a few of them. So in 2019, just a brief mention from the ACC, AHA, the Heart Rhythm Society. So those with cryptogenic stroke should have a AF which has to be ruled out. So it is for prolonged monitoring. So this is very important that silent AFs should be ruled out. And then from the SKY, so again, the consensus for the first time coming out in 2019, published in the CCI in 2019. So very clear here. So there has to be a rigorous process for selection, and the patient has to be identified as to who will be the best, who will benefit from it. And there has to be a close collaboration with between the cardiologist, neurologist, and also there has to be a lot of sharing of the data and discussion with the patient. And as far as the Europeans are concerned, this is the European position paper, so very detailed, very sort of meticulous. And again, here the data is that it's a strong statement for intervention, and age from 18 to 65 years in patients with cryptogenic stroke. And they go through a lot of points here, so I'll not go into that in detail. So it is available. And they also give points in terms of justification. So there is this overall justification. So they've taken these justifications from the data which has come from these main trials, the ones which showed decrease in the ischemic events. And also they give detailed justifications. They look at each and every part of it, and everything is sort of justified, which sort of is reasonably acceptable. And they also look at the undesirable effects. So even if the interventional treatment does not imply higher complication rates, but the only thing that is of concern is the AF. And overall, each neurological index event should, again, the same thing what was suggested by Sky, the same thing, neurologist and the stroke physician has to be sort of involved in it. And then the cardiologist comes into play here, and then after that, an agreement between them, and then the same has to be communicated to the patient, and then the pros and cons have to be discussed, and only then the PFO is considered for closure. This is the most recent one, and this is the last of my slides. And this is from the American Academy of Neurology in 2020. So this is the one which is sort of quoted a little more widely now in terms of its acceptance. So you have a level A recommendation. So they have divided into level A, level B, and C. So here ECG for AF has to be ruled out. And then you have these, a lot of these points, these recommendations where patients, when they're being considered for PFO, have to be considered. So there has to be a thorough evaluation. Brain imaging has to be done in different forms, vascular imaging, cardiac monitoring has to be done. And this has to be prolonged to make sure that the AF is not the causative factor here. And then bubble contrast, the echo studies, hypocoagulable studies, neuro opinion. And if only if there is if there's a high-risk alternative mechanism, so that should be given focus, and there should be no PFO closure. And the cardiologist should assess the PFO for suitability for closure. So not all PFOs are going to be suitable. So it's important that the anatomy should be looked at, the shunt should be looked at, and then the discussion with the patient and shared decision-making. So in the level C, so if there is an ASA with no large shunt, so it is not of, it's a level C recommendation. And in the older population, not much of data on that, but other traditional risk factors are there. So, and in patients with less than 30 years with single deep stroke, level C recommendation. So this is my last slide. So just to sort of summarize the points which I went through. So PFO is commonly encountered during stroke workup. The ROPE score may be helpful to identify. It's a supporting parameter. It is not one of the main parameters. It's very important that there is a comprehensive workup. And many a times a case-by-case consideration has to be done before PFO closure is considered. And especially when there is an alternative mechanism which has been identified, that should be treated first, not the PFO. And if PFO is thought to be the reason, closure is helpful, especially when it is embolic, when there is a large right to left shunt, and when there is atrial septal aneurysm. And the PFO closure reduces risk in select patients, especially below 60 years. And AF and procedural complications are going to be there, and this has to be kept in consideration, and this has to be discussed with the patient, and also about the outcome. So how beneficial it is going to be, the problems that are related. So the neurologist, cardiologist, and the patient. So it's a joint sort of decision. And those on long-term anticoagulation, it is unclear if the PFO closure is going to be beneficial. Thank you.
Thank you, Satish. It was a good summary of where we stand today. But I am sure that there are lots of questions will be asked in future. Lots of discussions will be there. Recommendations may change as science goes on. But anyway, I think at the moment there are some clear guidelines which you have exposed. I think that is a very, very intelligent and useful information for all of us. I have a few comments to make. And then maybe I think there was only one question on the chat box. What I say is, we have in our own personal experience, we have a large number of these systemic embolism people, and the thrombophilic disorders, particularly antiphospholipid antibody syndromes, hypereosinophilic syndromes, we have found them quite frequently. So unless we investigate them in a systematic manner, we may not be able to pick them up. And the second point I want to make is atrial fibrillation. In regard to atrial fibrillation, which applies to both the lectures, is that 80% of atrial fibrillation is silent and occult. Patient may have no symptoms at all, or it may be totally occult, which basically means that our resting ECG may not pick up. So you may have to do 48-hour Holter, you may have to do loop recorder, or you may have to use a telehealth facilities, or now this Apple Watch is available. So I think the point to be made is only 20% of AF is clinical. So a large burden of AF is subclinical and need to be looked into very thoroughly, which is important because that is one of the commonest causes of the stroke, whether it is, transient stroke or a hemiplegic stroke with a permanent disability. And then we have the left atrium. There was talk of left atrial velocity, left atrial appendage emptying, etc. Then left atrial shape also has been given good significance from many workers from Canada. So the more globular the left atrial shape is, they have done a shape analysis. The more globular it is, the highly likely that it will be a source of embolism. So even if the left atrium is not enlarged, even if the atrial fibrillation is not there, but if the left atrium is globular in shape, it can be a source of embolism. That is another information which I gathered over a period of time. And the aortic atheroma, aortic thrombosis was not mentioned, but I may make a comment here. Whenever we ask for transesophageal echo, we write there, focus, origin of, the stroke, cardio aortic source of embolism. We don't write cardiac source of embolism. We always write cardio aortic source of embolism because aorta also, as all of you have seen multiple number, you may have a plaque which is embolizing or a thrombus which is embolizing, and rarely it might just be a cholesterol deposit which is embolizing, or even more rarely an aortic sarcoma which is embolizing. And then another thing which we have used is PET CT and also late gadolinium enhancement of MRI, which can very easily distinguish the benign tumor from malignant tumor, and also distinguish a thrombus from a malignant tumor. Not infrequently, it is a difficult, diagnosis for an intracardiac mass to know whether it is a thrombus or a vegetation or a tumor, benign or malignant. In that clinical scenario, we have found PET-CT to be extremely yielding and extreme importance. I made very important decisions based on that. So that is what I would like to say a few words. And then coming to the lecture on PFO by Satish, we have had some experience on this. We had used intracardiac echo as well in closure of the PFOs. I distinctly remember one particular lady who had an embolism, and we tried to close the PFO which she had, but we were unable to do it because the PFO was serpiginous. It was the entry point on the right side was at a lower level, exit point on the left atrial side was at a different level. There was a tunnel. So you could call it as a serpiginous PFO or a tunnel PFO. These are extremely difficult to be closed. Another type of PFO which we found to be difficult to navigate is a PFO which is septated. There is a PFO, but there is a septum which is dividing the PFO. Then again, it becomes very difficult to navigate that PFO. Then the atrial septal aneurysm, we made a good mention of that. Both of you made that mention. There are 4 types, as you are aware. The atrial septal aneurysm fixed a convexity towards the right. That is the one which frequently embolizes into the systemic circulation. And then another type of atrial septal aneurysm, convexity fixed to the left atrium. Then the embolism into the pulmonary circuit. The third type is respirophasic movement of the atrial septal aneurysm, which generally does not embolize. And then non-respirophasic mobile atrial septal aneurysm, again, it is less risky to embolize. So which means the type of atrial septal aneurysm where the pouch is fixed with convexity to the right is the one which has a high risk of systemic embolism. So we take them quite seriously. But having said that, there is also another category which not exactly PFO, but related, a relative of PFO is atrial septal pouch. Atrial septal pouch, where the septum secundum and primum, they join at different levels. So there is a blind pouch either towards the right side, right atrium, or towards the left atrium. So blood forms a clot in that pouch and which embolizes into the pulmonary circuit. If the pouch is onto the right side, if the pouch is onto the left side, it embolizes into the systemic circulation. So there are again 4 types of atrial septal pouches, which is a modified PFO pathology. So these are not very common. We have personally seen only just a couple of them. But I heard Professor Nanda speaking about these pouches and showing some examples quite frequently. I have one question there to Satish. Is there any data how to deal with an acquired intra-atrial communication? Like, for example, an EP procedure has been done with a transseptal puncture, or a PBMV has been done with a transseptal puncture. So there you are leaving behind in a good number of them an intra-atrial septal communication, and most often they are not closed by a device as a rule. Some people do it when there is a significant shunt, but otherwise they don't close it. So is there any guideline, any data, any information you have on this subcategory of that?
There is no mention of that in any of the major studies that are used for PFO closure in terms of respect, reduce, close, and defense. But in terms of defense, they sort of focus a lot on shunting. So again, going by the guidelines also, there's not any specific mention on the acquired ASDs. But if we have to take it case by case, then I think if there is a significant shunting based on that and ruling out other causes, then one can look at it. But as far as guidelines are concerned, as far as studies are concerned, there's no mention. But one can look at it case by case.
Satish, is there an evidence that those patients who have undergone a atrial septal puncture, do they have cryptogenic stroke more than the general population?
I did not come across any data on that.
Because the pathology and the flow of blood across the patent foramen ovale is entirely different from the small hole that you make in the intraatrial septum when you do the procedure.
Right, it's definitely an interesting point, definitely an important clinical challenge. But as far as the studies are concerned, as far as the data on which the PFO closure is sort of based upon, there's not much on, I didn't come across anything as far as acquired ASD is concerned. So possibly they might be doing it now, which I'm not aware of, but it's not there in the
Actually, even if see the incidence of cryptogenic stroke in small ASD is much less, or maybe may not be there compared to PFO. So PFO, the blood flow pattern, what really contributes to cryptogenic stroke are entirely different from a small ASD. The small ASD as such may not give rise to too much cryptogenic stroke.
The most definitive indication.
What about the shunting also? It is important that we go through the shunting and see if there is a large shunting. So shunting is defined by the bubbles that go onto the left side, even with Valsalva. So some studies say 30 bubbles, some studies say 50 bubbles. So I guess if we have to take this, even though there is not much of data, but we have to go case by case, if the shunting is there and if the presentation is there, then one can sort of possibly look at it. So that's the way I would sort of look at it.
But all along, there had been some talk that the only real proof of PFO being the source of stroke is you need to demonstrate that there is a source like thrombus on the right side, either right atrium, IVC, IVC territory, etc., or DVT. Then you have to demonstrate that there is a PFO. Then you have to demonstrate right to left shunt. Then also demonstrate that there is the location of the stroke in the systemic circulation. The only definitive evidence appeared to be if you can catch a thrombus in transit. That is and one where the thrombus is straddling the PFO. That is the most definitive sign that the PFO has to be closed. But otherwise, I mean, a lot of discussions are there. You have highlighted very well. I don't think the last word is yet said. True. Because you have to take into consideration the industry influence of how to use these devices, how often, etc. But I mean, this discussion will go on for quite some time. Any other comments from our other co-panelists?
Yeah, Dr. Raju, can I say something?
Yes, please.
As Dr. Satish, as you're on the hot seat today, let me ask you, there's a dream study that said that young women who have migraine and get their PFO fixed, the migraine disappears. Is it a fact?
There is data on that, where the migraine is also part of it. Migraine is also there.
So do you really believe in it?
Well, so there are a lot of things officially on a platform which I cannot discuss. But
Ravi, I have something to say on that, Ravi.
There's a big role in this. And even the FDA approval, many questioned because based on a 2B recommendation, there was a lot of focus on the statistics, which varied. The statistical model itself were not there. The follow-ups were not there. The numbers, the endpoints were not correct. So there are still a lot of questions that are being raised. So this is the other side of it. But I mean, we have to go by what the guidelines say, but we know very well what the issue is.
It left questions unanswered.
Placebo effect is always there. And two, migraine spontaneously disappears or disappears over a period of time.
Yeah.
As the vessels age, they become inelastic. So vasospasm or vasodilatation is muted. So the migraine disappears over a period of time. But recently I read a paper a week back where they have done this thing in people with migraine. Their conclusion is that it does help in some migraine patients.
Yeah.
But the fact remains it does not help in every migraine patient.
Yeah.
So I think we
50%.
have a lot of things to think about it. I don't think we have any last word said on migraine and PFO, etc. We need to be very careful on that. Manish, you have any comments on that?
Good afternoon, sir.
Good
First of
afternoon.
all, both were very excellent presentations. My question is to Dr. Govind. See, in patients who present with apparently cryptogenic stroke and age is relatively younger, less than 60, 65, in these patients, although it remains quite debatable how to choose a patient for, if a PFO is found, whether to go for closure or not. But my question is, are we in a position to deny closure in a patient who's relatively young and there's no other cause of stroke, because the second event may be catastrophic for the patient? So will there be a patient in whom we'll be able to say, we don't need to close PFO?
There was a comment on
I
this
will take the easy
question.
way out, Manish. I'm going to take the data and, I mean, for example, in a hypothetical way, sit with the patient and show the data and, let the patient make the decision. I wouldn't really sort of take a stand on that, but, it's based purely on data. We can sort of share it with the patient. And, but if you take it like if it's a young patient, the cumulative burden is more, the risk is more, and the longer years are there. So if all other causes are not there, and if there is not much of a deep infarct, then I think one can sort of look at it, but it's going to be a shared decision, not a individual. Definitely looking at the outcome.
I just have a couple of comments, Manish, on that, your question.
Yes, sir.
One is that a few years back, recommendation was, if you found a stroke, if you found a PFO and unable to prove that PFO is whether it is the culprit or the victim, they said that if you are unable to explain the stroke by any other etiology, and if the stroke is repeated, then they said there is a reasonable moral ground to close the PFO. That is something which they said. Second comment I would like to make is, when you do imaging studies, you will find a lot of silent infarcts. Absence of focal neurological deficit is not equivalent to saying that there was no cerebral infarct. If you really do, so before you take these decisions, it is important to look for from head to foot, right? Were there any silent infarcts, either in the brain or the liver, spleen, kidneys, etc., that will give you some idea whether there had been recurrent infarcts. Sometimes it is also possible to age the infarcts by its scarring pattern and then density pattern, etc. Rough age also can be decided on, Hounsfield units, etc. So that is another comment which I would like to make to answer your question.
Yes.
Any other thing? I think there's some questions on chat box. Can I go over that?
Yeah, briefly, because then
there are two questions.
Yeah.
One question, I think this is addressed to probably Professor Manjuran. Question is from Dr. Keshav. When the patient with rheumatic heart disease with severe mitral stenosis with or without atrial fibrillation presented with cardioembolic stroke, when should this stenotic lesion be intervened ideally? Question 1. Question 2. When should we prescribe anticoagulation? Question number 3. Which anticoagulation should be preferred? Is it vitamin K antagonist or direct oral anticoagulants? Dr. Manjuran.
See, the timing of anticoagulation depends upon the the extent of stroke. That has to be decided in consultation with the neurologist. If there is an extensive stroke, if we anticoagulate, there is always a risk that it can transform into an hemorrhagic stroke. So, in consultation with the neurologist, the anticoagulation should be started as early as possible. In my experience, what I have found is that they don't like oral anticoagulation to be started immediately, but they don't mind either unfractured heparin or low molecular weight heparin when they are really certain that there is no risk of a hemorrhagic transformation. Regarding oral anticoagulation, in a patient with mitral stenosis with atrial fibrillation, the newer or the direct oral anticoagulants are not indicated, and the oral anticoagulation which is recommended is vitamin K antagonist.
The first question you missed out. What he asked was, when should this stenotic lesion be intervened ideally?
Yeah. See, there is no contraindication from the cardiology side to intervene at any time. But if the patient has satisfactorily recovered and his stroke conditions have sufficiently stabilized, and I think as early as possible, if the valve is amenable for balloon mitral valvuloplasty, that should be done, because the stagnation of blood can be reduced, risk of thrombus formation, everything can be reduced. So that should be done as early as possible.
There is a follow-up question from Dr. Keshav. What is the benefit of rhythm versus rate control in atrial fibrillation patient? As AFFIRM study and RAILS trial says, there is no benefit. So what is your own thought process, Dr. Manjuran?
Yeah, see, if you look at this AFFIRM study and other studies where the rhythm and the rate control studies were carried out, there are a few limitations. For example, the patients who were on a rhythm control, they were actually moved out of anticoagulation, and many of them may have paroxysmal atrial fibrillation, and they may throw an embolus. So there is a limitation for both these studies. At the moment, I would say that all the patients with paroxysmal atrial fibrillation of short duration should be converted to normal sinus rhythm. There is definite evidence that paroxysmal atrial fibrillation of short duration over a short period, less than a year, are candidates for conversion to normal sinus rhythm, and the pulmonary vein isolation has been shown to be beneficial. But those patients who are on chronic atrial fibrillation, where it is a fully established atrial fibrillation, atrium is dilated, very often they may have scars in the atrium. There is no indication for indication for intervention to convert these patients to normal sinus rhythm. They are well off with oral anticoagulation and rate control.
Any more? Anybody else who would like to add?
Dr. Raju, I think.
Yeah, we have only 2 questions. We are done with that.
Yeah.
Would you like to give the closing comments?
Yeah, Dr. Bansal, would you like to give us the closing comments?
I think, as I mentioned, both the talks were wonderful. They covered an issue which is very pertinent clinically, and all the different aspects were covered. So I thank both the speakers for covering the topics very nicely. I thank Professor Raju sir for moderating the session and adding his valuable insights to this topic. And I also thank all the participants who joined for this this learning activity.
Thank you very much.
Thank you.
Thank you very much.
Thank you very much.
Have
a good day.
Thank you, Ravi, for inviting us for this program today. And it was a pleasant experience to associate with you in this type of programs. Thank you, Ravi, once again.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks to everybody. Bye-bye.
Thank you. Bye.